Normal newborn. Today, we'll be looking at newborn assessments. We know a full-term newborn is a baby born at 37 weeks or more gestation. Term newborns are evaluated in the delivery room immediately after birth to assure that they do not require respiratory or circulatory support. They have no birth-related trauma or congenital anomalies that require immediate intervention, and that they are transitioning as expected to extrauterine life. So let's start with the respiratory system. So what are you looking out for? Normally, the newborn's respiratory rate is between 30 to 60 breaths per minute. So in terms of assessment, you're looking out for the rate. What's its respiratory rate, especially when in a quiet state versus when active, because before each assessment, you want to be sure the infant is in a quiet state and has not been handled for at least 10 minutes before you start counting the respiratory rates. Again, you're looking out if the respirations are labored, are there retractions or grunting, what's his skin color, his heart rate, any heart murmurs. Again, they are obligatory nose breathers, so you need to check and be sure he's breathing properly. So as part of your nursing considerations, you want to keep the airway patent. You want to limit activities because this will help to decrease oxygen consumption. You want to monitor his blood gases and blood pressure. You also want to keep supplemental oxygen use limited to what is required. You don't want to use more than necessary. Again, you want to monitor for respiratory distress because if it's in distress, you're going to be seeing increased respiratory rates. There will be grunting, there will be nasal flaring, you will see intercostal retractions. And if any of this is present, then you'll probably need to prepare for possible intubation. In terms of nutrition, we are going to look at the infant's weight and height, head circumference, chest circumference. So we know that the newborns vary in size and shape, just as adults do, but full-term babies on the average tend to weigh between 5.11 ounces and 8.6 ounces, or 8 pounds and 6 ounces. So that's what the range is for their weight, usually between 5.11 to 8 pounds, 6 ounces. The body of a newborn is essentially cylindrical. They are usually between 19 and 21 inches long. Their head circumference slightly exceeds that of the chest. So for a term baby, the average circumference of the head is 13 to 14 inches. And the average circumference of the chest is between 12 to 13 inches. You also want to monitor in terms of nutrition, bottle feeding infants. You want to assess. You also want to assess situations that can increase demand on nutrition, such as sepsis, ventilatory distress, and stress. In terms of your nursing consideration for this client, you want to monitor volume of fluid intake. You also want to carry out your dipstick and monitor specific gravity of the urine. Remember, your dipstick test checks for acidity, the pH level, which would indicate the amount of acid in the urine, because abnormal pH may indicate a kidney or urinary tract disorder. Your dipstick will also check for concentration or specific gravity. Remember, the higher the value, it means the infant is dehydrated. So remember, high and dry. Also, you're checking for proteins. Low levels of proteins in the urine is normal. A small increase are usually not a cause of concern, but larger amounts may indicate a kidney disease. So you're also looking out for sugar, ketones, bilirubin, blood, and all of that. So that's what your dipstick will tell you. You also need to carry out a caloric value of the infant's intake and also monitor output volume in the first 24 hours. In terms of heat regulation, you want to assess the infant's ability to maintain normal body temperature. Remember that acidosis may develop if there's poor temperature regulation. So you want to provide regular monitoring of the infant's temperature. You want to adjust environmental temperature appropriately. Cover the infant. We can put him in a warmer or isolate. So that's your isolate here. So this is a clear enclosed crib that maintains a warm environment for a new baby. It also helps to isolate him or her from germs. A baby, especially a premature baby who cannot maintain body heat, can be protected from cold in this structure. In terms of assessing the CNS, the central nervous system of our newborn, or what you should expect to see in a normal newborn, we need to assess the reflexes. So if we start with this would be our tonic neck reflex, also called the fencing reflex, just like the spots, the fencing spots. So when the baby is lying down and their head is turned to the right or the left, as you can see in this case, the corresponding arm extends. So if you turn the head this way, the corresponding arm extends while the other arm bends next to their head. So this makes them look like they're about to start fencing. So this is the tonic neck reflex, and it usually vanishes around 6 months of age. There's also the Babinski's reflex, or the plantar reflex. It's actually a foot reflex that happens naturally in babies and young children until they're about 6 months to 2 years of age. This reflex is usually tested by stroking the sole of the foot. So when the big toe bends up and back towards the top of the foot, while the other toes spread out from one another, it's called the Babinski's reflex. So you can see the big toe bends up and back towards the top of the foot, while the other 4 toes fan out. So this is your Babinski's reflex. So you want to see a positive Babinski's reflex. So this is a normal normal plantar reflex where the toes bend inwards and not fan out. Another reflex would be you're checking for in this newborn would be the Moro reflex. This is actually an infantile reflex that develops between 28 to 32 weeks of gestation, and it disappears between 3 to 6 months of age. It's a response to a sudden loss of support and involves 3 distinct components. So you're going to see spreading out of the arms, which is abduction. You're going to see the pulling the arms in, which would be adduction, and then finally there's going to be crying. So this is your Moro reflex, almost like when you almost the baby feels like he's been dropped, and it's going to respond by this reaction. So this is your Moro reflex. We need to also assess the autonomic nervous system, looking out for the sucking, the rooting, and the swallowing reflexes. So the sucking reflex is probably one of the most important reflexes the newborn has. It's actually paired with the rooting reflex, in which a newborn searches for a food source. So when he finds it, the sucking reflex allows him to suck and swallow the milk. So that's your sucking and rooting reflex. Again, we are going to assess the infant's fontanelles. Are they bulging or fat or flat? So these are referred to as the soft spots, and it's one of the most prominent anatomical features of the newborn skull. So you're looking out for if there's any bulging or if it's flat. Again, you also want to check for severe hypoactivity or hyperactivity. You're looking out for assessing the infant's activity level, sleep, cry. Is he hyper irritable or is he depressed? You also need to look out for anatomical anomalies. For example, cranial anomalies like your hydrocephalus. Remember, hydrocephalus, there's accumulation of cerebrospinal fluid within the brain. So you want to assess for that. You also want to assess for microcephaly, which is a condition where infants are born with a smaller than average head size. You also want to assess for other spinal anomalies also. Still on the CNS, you also need to assess for paralysis or paresis. For example, you're looking out for Erb's palsy or Duchenne's palsy. It's a form of obstetric brachial plexus palsy. So it occurs when there's an injury. So these are our brachial plexus here. So it occurs when there's an injury to the brachial plexus, specifically the upper brachial plexus, and it occurs at birth. The injury can either stretch, rupture, or avulse the roots of the plexus from the spinal cord, and it is the most common birth-related brachial plexus injury. So you want to look out for that palsy in the infant. Again, you also want to look out for Bell's palsy, where you have a condition that causes paralysis of the face and drooping of the face. So facial nerve palsy in the neonatal period can be a result of few reasons, including congenital reasons, trauma at the time of birth, or even developmental reasons. You also want to assess the infant's lower extremities. Again, if there are life-threatening problems, you need to deal with them immediately. If there's absence of swallow reflex, we need to deal with that. If the fontanelle is bulging, we need to attend to that. If there's any cranial nerve injuries, that must be attended to in the infants. In assessing parenting, you want to assess the infant as well as the mother and the father. So in terms of the infant, you're looking out for what's their behavior. Again, you need to understand that there are individual differences in infants, so they all cannot be the same. For the parents, you're looking out for their pattern of touching the infant. Are they accepting of the infant? Is there reciprocity of interaction between the infants and the parents? If the child looking for attention is a mother giving that attention. You also want to assess the age and developmental level of the parents. Teenage parents and more mature parents would differ in their response to parenting. Again, is there any guilt, anxiety, or grief reaction? And what's the ability to interact? You want to report any deviations. Another assessment of the newborn would entail the ABGA score, which is performed at 1 minute and 5 minutes of age. So you need to use this table to score the infants. You look at the appearance. If the whole body is pink, you want to give a score of 2. If the extremities are blue, you want to give a score of 1. If the child is cyanotic, you want to give 0. With pulse also, if the pulse is greater than 100 beats per minute, you want to give a score of 2. Or less than 100 beats per minute, you want to give a score of 1. If there's no pulse, you want to give a score of 0. If the baby cries and pulls away, you want to give 2. If the grimaces or has weak cry, you want to give 1. If there's no response to stimulation, you want to give 0. If there's active movement, it gets a score of 2. If there's flexion of the arms and the legs only, it gets a score of 1. If there's no movement, it gets a score of 0. In terms of respiration, if there's a strong cry, it gets a score of 2. For a slow, irregular respiration, it gets a score of 1. If the infant is not breathing, it gets a score of 0. So generally, scores between 0 to 3 is regarded as poor. Between 4 to 6 is regarded as fair. And between 7 to 10 is regarded as excellent. In terms of measurements at birth or at term, the weight is usually of the infant ranges between 6 to 9 pounds or between 2,700 to 4,000 grams. The normal 5 to 10% weight loss in the first few days is expected to be regained within the next 1 to 2 weeks. In terms of length, they're usually between 19 to 21 inches or 48 to 53 cm. The head circumference is between 13 to 14 inches, which is 1/4 of the body length. And the chest is usually 1 inch less than the head circumference, and that's between 13 to 12 to 13 inches. In terms of assessment of the vital signs, you want to assess the temperature. We can do that through the rectal means or routes, but this is not recommended as routine because of potential for rectal mucosal irritation and also increased risks of perforation. We can also check the temperature through the axillary means, and we should expect to see between 97.7 to 99.7 degrees Fahrenheit. If you also want to check the apical rate, where if the infant is sleeping, the rate should be between 100 beats per minute. If it's awake, it should be within the ranges of 120 to 140 beats per minute. And if the infant is crying, it should be an upwards of 180 beats per minute. So you want to assess this by auscultation for 1 full minute, especially when the infant is not crying. In terms of respirations, we are expecting to see between 30 to 60 breaths per minute. It's primarily diaphragmatic and abdominal. It should be synchronous with chest movements. There may be short periods of apnea that lasts less than 15 seconds. And since the neonate is an obligatory nose breather, it's important to keep the nose and the mouth clear. In terms of blood pressure, the range should be at least between 65 over 41 millimeters of mercury in the arm and in the calf. In terms of posture, you would notice resistance to extension of the extremities, which is normal, and the infant will maintain fetal position for several days after delivery. The skin, we know in the newborn, is sensitive to drying. You also want to look out for erythematosus, that beefy red color that occurs for a few hours after birth, and then it changes to pink, or as expected for racial background. Again, acryocyanosis, which would be a bluish discoloration of the hands and the feet, is normal for 24 hours. Another thing you should look out for is vernix caseosa. So that, which is this protective gray, white, fatty substance of cheesy consistency covering the fetal and newborn skin. You don't want to attempt vigorous removal of the vernix caseosa. There's also the lanugo, so which is this light distribution of downy fine hair, maybe over the shoulder, forehead, and cheeks. Again, if there's so much of them, extensive, or if it's extensive amounts, then that's indicative of prematurity. We're also looking out for milia, which is the distended sebaceous glands that appear as tiny white pinpoint papules on the forehead, on the nose, on the cheeks, and the chin of the neonate. They disappear spontaneously in a few days or weeks. So there's also the pigmentation that you would assess in the infant. You could see Mongolian spots. So this would be Mongolian spots, the bluish gray or dark non-elevated pigmentation area over the lower back and buttocks. It's present at birth in some infants, especially African American, Hispanics, Asians. You're also looking out for birthmarks like the telangiectatic nervi or stock bites. So this would be our stock bite. It's a cluster of small, flat, red localized areas of capillary dilatation. It's usually seen on the eyelids, the nose, the nape of the neck, like this infant is the nape of the neck. It can be blanched by pressure of the finger, and it usually fades during infancy. There's also the nervus vasculosus. So this would be our nervus vasculosus, or the strawberry mark. You can see the color looks like strawberry. So they are raised, they are demarcated, they are dark red, rough surfaced, capillary hemangioma. You see it in the dermal and subdural layers. They grow rapidly for several months, and then they begin to fade, usually disappear by 7 years of age. There's also the nervus phlemus, or the port wine stain. So this is our port wine stain, which is usually reddish, usually flat, is a discoloration that's commonly seen on the face or neck. It does not grow, and again, it doesn't fade. So this is your nervus phlemus. In terms of assessment of the infant's head, remember the head may appear asymmetrical because of overriding of cranial bones during labor and delivery or the molding process. So you want to look out for the fontanelles. These are the soft spots at the junctions of the cranial bones. So these are the fontanelles, this is the anterior fontanelle, and this is the posterior fontanelle. So with the anterior fontanelle, you can see it's diamond-shaped. It's between 2.5 to 4 cm. It's easily felt, usually open and flat. There may be moderate bulging if the infant is crying or stooling, that's expected. Sustained bulging, however, occurs with increased intracranial pressure. You also see depressions in the fontanelles with dehydration. There may be slight pulsation in the fontanelle, but the anterior fontanelle should close by 18 months of age. With the posterior fontanelle, it's usually triangular and measures between 0.5 to 1 cm. It's not easily palpated. This should also close between 8 and 12 weeks of life. Still on the head, we could look out for Kefal Hematoma, which would be a collection of blood under the periosteum. So this is our periosteum. So there's a collection of blood under the periosteum of the cranial bone, usually appearing on the first and second day. Again, you will notice it doesn't cross the suture lines, and it disappears in weeks to months. You could also look out for caput succedaneum, which is a localized soft swelling of the scalp, often associated with a long and difficult birth. So it's present at birth, it overrides the suture line, or the fluid is reabsorbed within hours to days after delivery. Again, you also want to assess the infant's face. There should be symmetrical distribution and movement of all features. If you notice any asymmetry, it may signify paralysis of facial cranial nerve, which would be your Bell's palsy. You also want to assess the eyes. Eyelids may be edematous. The pupils should be equal and react to light. There should be corneal reflex, blink reflex. The corneal reflex actually an involuntary blinking of the eyelids, which is elicited by stimulation of the cornea, such as by touching or by a foreign body. Also, you're looking out for areas of subconjunctival hemorrhage. So there shouldn't be any of that. When you're assessing the mouth, you want to ensure the infant sucks well when stimulated. There should be hard and soft palates, which should be intact. The gag reflex, the rooting reflex should all be intact. In terms of the ears, you want the pinna of the ear to be parallel with the inner and outer canthus of the eyes. Low-set ears are associated with chromosomal abnormalities. They are associated with intellectual delays and internal organ abnormalities. You want to assess the ear and evaluate hearing by an arousal response to loud or moderately loud noise. You also want to assess the statu reflex. In terms of the chest, breast enlargement, as you can see in the picture, could be seen in the infant. It could last up to 2 weeks, and it may occur in both males and females. When we assess the abdomen, we expect it to be cylindrical and slightly protuberant. If you look at the umbilical cord, it's initially white and gelatinous with 2 arteries and one vein. It looks shriveled, as you can see, and black by 2 to 3 days. It falls off within 1 to 2 weeks. So you want to look out for foul-smelling discharge, which is indicative of infection requiring immediate treatment to prevent septicemia. Again, the first stool is black and tarry, which is your meconium. It's usually passed within 12 to 24 hours, and then followed by thin green-brown transitional stools the third day, then 1 to 2 formed pale yellow to light brown stools per day with formula feeding, or loose golden yellow stools with sour milk odor with every breastfeeding. In terms of assessment of the genital urinary system, urine is present in the bladder at birth, but neonates may not void for 12 to 24 hours. Again, you may notice brick red spots on diaper from passage of uric acid crystals. Thereafter, they usually void pale yellow urine 6 to 10 times per day. In the female, the labia is relatively large and approximated, may have normal thick white discharge, so that is expected. A white cheese-like substance, which is the smegma, or you could also see blood-tinged discharge, which would be your pseudo-menstruation. So you can see our pseudo-menstruation in this infant's diaper. For the males, the testes can be felt in the scrotum. In terms of the trunk and extremities, the arms and legs should be symmetric in shape and function. The hips should be able to abduct to greater than 60 degrees. There should be symmetric inguinal and buttocks creases. So you can see these creases are not symmetric. So this will tell you there's hip dislocation. Again, the foot should be in straight line. You also need to assess the reflexes. Again, we already talked about the rooting and the sucking reflex. So that will be our rooting and sucking reflex. We're also looking out for the pupillary reflex, where there's constriction on exposure of light. You're also looking out for the Palmer's reflex, which is pressure on palm elicits grabs. So you see, once they feel a pressure on their palms, they grabs whatever it is. So this should usually fade by 3 to 4 months. There's also the plantar grafts. So these are your plantar grafts, where pressure on the soles behind the toes elicits flexion. So you can see the toes are flexed. So this should lessen by 8 months. There's also the tonic neck or the fencing position, which we already talked about. There's also the Moro deflex, which we already talked about, which is elicited by sudden disturbances in the infant's immediate environment, where the body will stiffen, arms will be in tense extension, followed by an embrace gesture with thumb and index fingers in a C formation. So the Moro deflex disappears after 3 to 4 months. There's also the positive supporting reflex, where the infant will stiffen legs and appear to stand when held upright. There's also the stepping reflex, which you need to assess. When held upright with one foot touching a flat surface, the infant will step alternatingly, almost like he's stepping. So this should fade between 4 to 5 months. And again, there's also the Babinski's reflex, where we said stroking the sole of the foot from the heel upwards across the ball of the foot will cause all toes to fan. So this reverts to usual adult response by 12 months. In terms of your potential nursing diagnosis in the newborn, there could be ineffective airway clearance, thermoregulation ineffective, growth and development altered. So in terms of your plan, you want to establish airway, maintain its airway, observe for Apgar score at 1 and 5 minutes. You want to clamp umbilical cord. maintain warmth and keep exposure to the environment minimal. You want to place identification band on the baby and mother. So that's your identification band. You also want to administer prophylactic medication. So there's eye prophylaxis. Usually newborns receive erythromycin eye drop after birth to prevent pink eye in the first month of life, also called ophthalmia neonatorum. We would also need to administer intramuscular vitamin K for first 3 to 4 days of life. Remember, the newborn is unable to synthesize vitamin K. So we will need to give or administer IM vitamin K. You also want to record the first stool and the urine, weigh and measure the baby, observe and support mother-infant bonding, begin and monitor feeding schedule. So before initiating first formula feeding, check for readiness. Are there active bowel sounds or absence of abdominal distension and lusty cry? And also for absence of gagging, choking, regurgitation. So all of these are associated with tracheoesophageal fistula or esophageal atresia. So you want to check by giving a small amount of sterile water. You don't want to give glucose because glucose is irritating to the lungs. Again, since colostrum is readily absorbed by the gastrointestinal and respiratory system, breastfeeding may be started immediately after birth. In terms of umbilical cord care, you want to clean the cord and surrounding skin. No top baths until the cord falls off. Fold diapers below to maintain dry area. You don't want to have the diaper cover the cord. Report redness, any drainage or foul odor. In terms of care of the penis, in the uncircumcised infant or newborn, do not force retraction of the foreskin. So that's your foreskin there. You don't want to force retraction of the foreskin. A complete separation of foreskin and glans penis takes from 3 to 5 years. So parents should be told to gently test for retraction occasionally during the birth or during birthing, and when it has occurred, gently clean glans with soap and water. In the circumcised newborn, where they would have carried out surgical removal of the prepuce or the foreskin, so these are circumcised newborn's penis, you want to ensure signed permission before carrying out circumcision. Provide comfort measure during and after the procedure. Post-procedure, you want to monitor for bleeding and voiding. You also want to apply A&D ointment or petroleum jelly, except when plastibell is used. Teach parents to clean area with warm water, squeezed over penis, and dry gently. A whitish yellow exudate is normal and should not be removed. If plastibell is used, report to pediatrician if it has not fallen off in about 8 days.